or other hyperemic agent to achieve maximal hyperemia. This ratio represents the fraction of normal blood flow through the stenotic artery. A normal FFR value for all vessels under all hemodynamic conditions is 1.0. FFR values less than 0.75 are associated with abnormal stress tests. A post-PCI FFR of 0.94 or greater is associated with better outcomes.
The preparation of the pressure wire is very important when you do an FFR. This is the pressure wire.
Hand off the wire to the scrub tech using sterile technique. Do not flush the wire. Place the hoop with the wire on the patient table and remove the phone jack connector. Plug the phone jack connector into the PIM FFR and the wire will auto zero. Do not touch the wire at this time. Once the wire is zeroed, remove it from the hoop and shape the tip as needed. Note that the transducer is 3 centimeters from the tip.
The interpretation of FFR is very important. And how do you interpret the FFR, especially for intermediate lesions? Here you see the pressure trace and the FFR is 0.80, and after giving adenosine you see there's a fall in the FFR from 0.90 to 0.74, suggesting that it is hemodynamically a significant stenosis. Any FFR less than 0.75 is significant, suggesting that the stenosis is hemodynamically significant. This is a pressure tracing to look at the gradient, and this is 0.7 is the FFR in this patient. This patient we did a stenting. Thank you very much for your patient hearing. I look forward for a live case tomorrow morning where the patient, Mr. Ramaswamy, has a 50-60% lesion in the proximal LED artery, and he's also got a distal 85% stenosis presented to me with acute coronary syndrome. And what we are going to do is do an FFR for the proximal lesion, and if the pressure wire in the IVUS shows that there is huge plaque burden, we are surely going to go ahead and stent it. See you tomorrow morning. Thank you. Bye-bye. This is a case of IVUS, intravascular ultrasound, on an intermediate 50 to 60% borderline lesion in the proximal LED artery on a coronary angiogram in a patient with exertional chest pain. I had to decide on the IVUS on grayscale and virtual histology on the lesion and decide medical treatment, including high dose 40 milligram rosuvastatin versus PTC and stenting. This is puncturing of the femoral artery, and I'm just introducing a wire, and over the wire introduced 6 French Hemoquid sheath. This is a guiding catheter. It's a 6 French XB extra support guiding catheter from Cordis. So I regulate the coronary artery with the guiding catheter, just applying a threefold manifold. This is the cannulation of the coronary artery, and you can see the LED artery in the proximal side of the LED artery. You see a 50 to 60% borderline stenosis. The question was whether to stent it or to leave it on medical treatment with high dose statins. I'm now introducing a BMW wire through the guiding catheter. It is coming to the tip of the guiding catheter. You could see the BMW wire entering the LED artery. I crossed the stenosis with the BMW wire, and you can see the BMW wire distally placed in the LED artery. This is a check shoot to look at the BMW wire well placed distally in the LED artery. Here is a fixed image to show the 60% lesion in the proximal LED. I am now removing the IVUS catheter. This is a Golden Eagle IVUS catheter. That's the tip of the catheter, which has a lens by which we can look into the lumen of the coronary vessel, both on the grayscale and virtual histology, to look at the plaque burden and to know whether it is a fibrous plaque or a fibrofatty or a fatty plaque, and also to look at the calcified lesion. Here you can see the IVUS image, the lens of the IVUS catheter at the tip of the guiding catheter, and on the IVUS image you can see the lumen of the IVUS catheter. The IVUS catheter is now advanced from the proximal to the mid segment of the LED, and then there is a pullback with a bookmark just after the lesion and at the lesion, and on the IVUS image you can actually see the plaque burden. It's a significant plaque burden showing fibrous tissue, moderate fibrofatty tissue, some calcified specks, and less of the fatty component. The center is the lumen of the IVUS catheter, and then is the lumen of the coronary artery, and here you can see the significant plaque burden all around. Looks an eccentric plaque with some calcified specks and fibrous tissue and some fibrofatty plaque, and there is a less component of the fatty tissue. If you look at the lumen of the coronary, the plaque burden appears to causing close to 70 to 80% stenosis in the proximal segment of the LED artery. If it is just a fatty plaque, best would be to leave it on high dose statins, including rosuvastatin 40 mg or 80 mg atorvastatin. But since here there is more fibrotic plaque, the decision was to dilate it with a balloon and put a stent. Here you can see a long stent which I have deployed. It's a 2.75 by 23 mm stent. This is a Xience Prime stent which I deployed at 14 atmospheres. I did a post-stent IVUS examination to look at the struts of the stent to be well opposed on the arterial wall, and took a pullback. You can see the IVUS image with a pullback on the strut of the stent, and you can see that the struts of the stent are not so well opposed on the arterial wall, and at the 10 o'clock position you can see some plaque burden still there. Best would be next, I went with the 3 by 15 mm Sprinter balloon and post dilated the stent at 20 atmospheres so that the struts of the stent get well opposed on the arterial wall. This is after post balloon dilatation. I have taken an IVUS image, and this image shows the struts of the stent are well opposed on the arterial wall, which is a perfectly well deployed stent. Even on the coronary angiogram screening, you can see the angiogram looks perfect in terms of stent deployment. This is a final image to show the struts of the stent extremely well opposed on the arterial wall on a pullback. This image is a post-stent deployment, and you can see the stents well opposed on the arterial wall, and you can also see a chroma with the color flow mapping, which shows a very widely open lumen of the coronary artery. The point to understand is that all moderate or intermediate lesions need an IVUS. If it has a high fat plaque burden on the IVUS, then this would respond very well to high dose statins. It may be a 40 mg rosuvastatin or a 80 mg atorvastatin. Fibrotic and calcified plaque burden are best treated mechanically with balloon dilatation and stent deployment. This patient, being a diabetic, if you look through the IVUS image, had diffuse minor fatty plaques throughout the length of the coronary artery, both the distal, the mid and the proximal segment of the LAD. Where I stented was the fibrotic lesion in the proximal segment of the LAD as seen on the IVUS, but the minor fatty plaques throughout the length of the coronary should respond very well in terms of regression of the plaque on a high dose 40 mg rosuvastatin, which should be given at least for 6 weeks post stent deployment.